Good evening. Welcome to Memorial. My name is Marjorie Calvetti. I'm the Director of Medical Imaging here at Memorial. I am happy to share with you this evening a presentation of Neurointerventional Radiology, some services that we've been providing at Memorial for a very long time, but we're happy to debut some new services that are coming live here in our facility. We have 4 physicians that are part of our Neurointerventional Radiology program that are going to be available this evening. First, we'll hear a very nice conversation and introduction to what is Neurointerventional Radiology. I can barely say it, so by the time you leave here, you'll know what it means in people terms, so it won't be these big fancy words for you to understand. So Dr. Augusto Elias will come up and go through and explain to you Neurointerventional Radiology, and he comes with a great fellowship from the University of Michigan to Memorial Medical Center, so he has a lot of information to share with us. We will then have a panel of our radiologists come up and have a question and answer, so that if you have any questions you would like to ask the physicians, they will provide their very intelligent information and answers to you. Not in any specific order, not to hurt anybody's feelings. First, Dr. Robert Burke will be on the panel. He's one of the neurointerventional radiologists here at Memorial. Dr. Craig Russo, he is a neuroradiologist, so if you want to ask a question, ask him the difference between a neuroradiologist and a neurointerventional radiologist. He will be on the panel. And then Dr. Casey Mealy, who is an interventional radiologist as well, will be on the panel. So we will allow Dr. Elias to walk through the presentation. I think that you will have plenty of time for question and answers at the end. So please do stick around and ask those questions. And without further ado, I will let Dr. Elias come join us.
Well, thanks for having me here tonight. And first of all, I want to say I have nothing to disclose. So question is, what is neurointervention? I think that's the question that everybody came here to find out tonight. So neurointervention is a word or a specialty of medicine that is used to describe a treatment approach to conditions that occur within the vessels of the brain or within the spine. It's utilized in place of more invasive procedures such as open surgery, and neurointervention is considered a minimally invasive procedure. So in terms of conditions that affect the brain, what we do is that what we take is a catheter or a tube, small tiny tube, through the groin into the arterial system of the body. We use the arteries as a superhighway in order to navigate ourselves to the problem area in the brain. And then once we are in the brain, then we'll deliver medications or use additional devices to treat the problem area. In terms of conditions that affect the spine, we treat compression fractures, tumors of the spine, and narrowing of the spinal canal, which we tend to call spinal stenosis. Again, we treat these by using tubings, catheters, and also cannulas. In terms of the spine, what we can do is that we'll place the patient in on his or her belly, and then go through the skin, and then access the bone framework of the spine, and then treat it. How do we make all this possible? So in terms of, this is where radiology comes in. What we have is a highly specialized and advanced technology where we can transmit pictures and images into a big screen such as this one, and specialists such as myself and my other teammates, what we do then is that we can directly visualize where we are taking these catheters and tubes into the problem area and then treat directly with direct visualization. So there are many conditions that we can treat and offer. The ones that I'm going to concentrate tonight are the more common ones and the more critical ones, and these are stroke and aneurysm. So strokes can be divided into 2 main types. The first type, which is the most common one, and it's the one that most people are aware about, it's ischemic stroke. And this is when a clot blocks the artery that carries blood to the brain tissues, and by doing so, there's lack of oxygen. And as a consequence of this, brain cells die, and they die at a fast rate. 2 million cells per minute are dying. So naturally, this increases the risk of permanent brain damage, disability, and death. So what's important here is to recognize the symptoms and getting fast medical attention. Identifying what the patient needs to have done and bringing them to a highly specialized medical center, such as Memorial. The second type is hemorrhagic stroke, and this happens when an artery in the brain bleeds. And there are two main causes, or the two more common causes that causes an artery in the brain to bleed is an aneurysm, which is pretty much like a focal weak spot in the vessel wall. And then there's an arteriovenous malformation, which is a fancy name, pretty much to describe a tangle of abnormal, fragile vessels that tend to bleed in the brain. So how common is stroke? How common is ischemic stroke? So approximately 795,000 strokes are new or recurring in the United States. And this leads to being the #1 cause of adult disability in the United States and the third leading cause of death in America. Stroke happens 1 every 40 seconds, and a death from a stroke-related injury occurs every 3 to 4 minutes. And this costs a lot of money to the American people. $7 billion in 2009 was quoted by the American Heart Association as the cost related to medical costs related to stroke and disability. So what are the symptoms of an ischemic stroke? So there's sudden numbness or weakness of the face, arm, or leg, and this is usually on one side of the body, sudden confusion, difficulty speaking or understanding speech, sudden difficulty seeing in one or both eyes, sudden difficulty walking, dizziness or loss of balance or coordination, and sudden severe headache with no known cause. What are the risk factors for ischemic stroke? Being a male, over the age of 55, of African American descent, diabetes, hypertension, hyperlipidemia, which is fat within the blood, smoking, and atrial fibrillation, which is another word for saying irregular heartbeat, and family history of stroke. So how are strokes diagnosed? So this is where Memorial comes in. We are a highly specialized tertiary center where there are highly specialized medical professionals and specialists who dedicate themselves solely to treating stroke. And we all work together as a team to diagnose, treat, and provide early rehabilitation to stroke patients. So what happens when a patient comes with these symptoms to a hospital? So the first thing we do is we perform a CT scan, a CAT scan, and the idea here is to identify whether the stroke is ischemic or whether there's a bleeding stroke, a hemorrhagic stroke. If the stroke is ischemic, then we obtain more advanced imaging, which is a CT angiography, fancy word to saying CT scan with dye within the vessels of the brain. And there we can precisely locate the site of blockage, how much blood flow is being blocked and going to the distal tissues after the blockage, and what's the tissue that is at risk that we can potentially save with neurointervention. So how are strokes treated? The rule of thumb here is time is brain. Recall that I just mentioned that 2 million cells are dying per minute. There are FDA-approved medications and interventions, and which the one that's the medical one, which is a medicine, if you will, it's called tissue plasminogen activator, TPA, and that's a clot-busting medication that can be given via the vein on the arm. And there's a specific time window for this. And that's usually from 3 to 4.5 hours from the initial onset of stroke. Reason being is that is so strict is that there has been studies demonstrating that if we go past that window, there's an increased chance of that stroke to go into a hemorrhagic transformation, that the stroke itself will convert itself and bleed. There are also some devices, and this is where the neurointervention team comes in, that is dedicated to breaking the clot. In this, again, there's a specific time window from 6 to 8 hours from the initial onset of stroke. Again, in order to avoid, if we go past the 6 to 8 hours, there's data showing that the stroke might turn into a hemorrhagic one. And the devices that are FDA approved and currently out there in the market are called Solitaire, Penumbra, Mercy, and Treva Pro. These are all fancy names. I'm going to show you in one of the, a video showing what I just mentioned and what these names mean. So pretty much when you see you're seeing here in the animation, there's this bright light. This is just demonstrating the clot, which is when it travels, it's called an embolus. That's the fancy medical terminology for it. It travels into the brain, it accessing the blood vessels of the brain, and then it lodges into one of the vessels of the brain. And then as you can see, blood flow now is not flowing more distal to it. That's called an ischemic stroke. So what we have is, this is one of the devices, the Trevo device. It's a stent device where we take it up there, and what we want to do is just grab that clot out of the artery and bring it outside and bring it out. So with the aid of a wire and a catheter, we pass this stroke distally. We put the tubing or the microcatheter past the stroke as well, take the wire out, and here the goal is to reestablish flow, perfusion to that damaged tissue. And so, I mean, this is a little bit on the slow side, and I apologize, but this is the deployment of the stent, and then you're going to see a zoom video in a cross-sectional view of the clot opening up and the struts of these stents pushing out the clot in order to provide circulation. Once we have the stent deployed, we have it for 5 minutes. We want brain tissue to be oxygenated again, have oxygen. So this is, again, demonstrating the flow past to the trouble area and reperfusing that damaged tissue. Once we're ready and we have engaged the stroke, this is a more proximal catheter. It's a balloon catheter where we arrest flow and pull the whole thing out. Clot and everything. Clot and stent goes inside the main catheter, and we establish the flow. So now let's focus on hemorrhagic stroke. We already discussed what ischemic stroke is and how to treat it and manage it. Hemorrhagic strokes are mainly caused by an aneurysm. And as I mentioned before, an aneurysm is a weak spot in the blood vessel, and it's likened to a bubble. There are different types of aneurysms. One is a fusiform, which is pretty much that the whole vessel is not normally dilated or enlarged. There's a saccular one, which is that focal outpouching. And there's a dissecting one, which is that there is damage to the vessel wall and they spread out. And that's usually associated many times with trauma. Aneurysms can affect any vessel of the body. However, inside the head, they're the ones that cause the hemorrhagic stroke and can lead to brain damage and death. So how common are aneurysms? They're uncommon, not very common. They occur about 6% of the U.S. population. Out of that 6%, 30,000 rupture each year. Females have a greater disposition than males, and 20% of patients suffer multiple aneurysms in their lifetime, out of that 6%. Average age ranges from 40 to 60 years. What are the risk factors? There are mainly two: smoking and family history. There are also some inherited conditions that predispose patients from getting aneurysms. How are these treated? So what's important here is to get high-quality image in order to determine what the size and shape and location. Aneurysms can be treated both with open surgery and also with what I do, which is coiling procedures, minimally invasive coiling procedure. For the past 40 years, the mainstay had been surgery, and then over the last 15 years, interventional and have grown. Endovascular procedures have grown and taken more of a important role in the treatment of aneurysms. Having some difficulties here with my next slide. Size, location, there, yeah, open that one. And I apologize for this. I'm having technical difficulties. So how are aneurysms diagnosed? Unfortunately, most of them are not diagnosed, and the only time they're detected is when they rupture and the patient comes into the emergency room. However, large unruptured aneurysms can present with symptoms such as vision changes, pain behind the eye, nerve paralysis, there's localized headache, neck pain, nausea and vomiting. And then there's an increasing number of aneurysms that are being detected incidentally, and it usually happens when a patient comes to their primary care physician saying, I have pain behind my eye, I can't see very well, I have these unusual headaches, and then the family practitioner will refer the patient to get a CT or an MRI, and then these are detected via imaging. However, the gold standard, the way to better identify these aneurysms is to do digital suppression angiography. And then again, that's what we do here at Memorial, our team here. And again, it's a minimally invasive procedure. And what we do is we insert a catheter through the groin. The puncture at the groin is, say, as big as a pencil tip. And then through there, we'll thread the catheter up via imaging, direct visualization, into the problem side of or where the aneurysm lies inside the brain. We'll put some liquid dye or contrast material, and that will help us identify the size, the shape, and location of the aneurysm. And then with all this information, then we can come together as a team and also consult with neurosurgery and neurologists and ask to say, well, is this patient a good candidate for an open surgery, or is this patient a good candidate for a neurointerventional procedure? So what happens when an aneurysm ruptures? There's blood, the vessel ruptures and there's blood in the spaces of the brain. And this is called a subarachnoid space. Patients complain and when they're in the ED saying, this is the worst headache of my life. That's a very typical complaint when they come to the ED. Patients experience nausea, vomiting, lethargy, and loss of consciousness. This is considered a medical emergency because 10 to 20% die before even getting to the hospital. Another 40 to 50% die within the next 30 days of related complications to the bleed. And out of those 50% that survive, they remain dependent on others for daily activities. Hospital course is a long one, and it has to be in the intensive care unit for 2 weeks at least. And again, this is to identify the potential complications, because once the patient survives the bleed, now we have to watch for these complications. And the more common ones is hydrocephalus, which is another fancy word of saying excess fluid within the brain tissue, and vasospasm, which is the abnormal narrowing of the vessels. Blood is very irritant to the blood vessels, to the outside of the blood vessels in the brain. If vasospasm occurs, then there's an increased chance of an ischemic stroke because then there's lack of oxygen and blood flow to those tissues. So how can aneurysms be treated? So there's data showing that small aneurysms, incidental small aneurysms, and based on the location and shape, can be observed. If the patient is asymptomatic and they're like 5 to 7 millimeters in the anterior or in some certain locations of the brain, they can be observed. Surgery is definitely an option, and this is called open clipping. It's performed by neurosurgeons. And hospital stay in the ICU is 2 to 3 days, and then the patient will go with light restricted activity to their home. Then there's the endovascular coiling technique, which is what we're providing here at Memorial. And this is performed by a neurointerventional surgeon. And these patients will spend approximately, again, 1 to 2 nights in the intensive care unit for monitoring, and then they're discharged home with minimal restricted activity. Occasionally, aneurysms do recur with coiling, and we have to bring the patient back and retreat. This is an example of that saccular focal outpouching aneurysm that I was talking to you about. And aneurysms tend to occur mainly at branching points of arteries. That's the weak spot. Embryologically, it's a weak spot of the artery. And this is the technique that we provide here at Memorial. As you can see, this is a saccular focal outpouching, a bubble, an aneurysm bubble. And we are taking a catheter here, And what you're looking at inside the dome or inside the sac itself is that meshwork is coils. These are platinum coils. And the idea of the platinum coils is to form a framework for clot to form there. The body will form a clot in that area and seal the aneurysm off. The other picture that you're looking at here is sometimes based, again, on size, shape, and location, especially the diameter or the length of the neck. We might have to put what is called a stent. And the stent, pretty much what it forms is a scaffold and protects that neck so that we can safely place the coils with them migrating to areas that we do not want them to go. So in conclusion, neurointerventional treatments are considered less invasive than more traditional modes of treatment and yield optimal treatment outcomes. However, it's important to note neurointervention is not the appropriate treatment for every individual patient case. And the advantages of endovascular surgical techniques over traditional treatments such as open surgeries, shorter recovery times, fewer complications, and less post-operative pain. My reference, and this is my pride and joy. Thank you. We'll be happy to take some questions now. I'm inviting my team over here, Dr. Russo, Dr. Mealy, and Dr. Burke. I shouldn't say my team, I say my colleagues.
Hello, thank you. Well, thanks for that, Dr. Elias. I know we have some medical professionals that heard that talk and some non-professionals. So we're interested in answering any question, whether no matter how basic or how advanced you may think it is. Can we open it up to questions? Please go ahead. Yeah, that's a good question. Now, the first thing I want to say is the common background that we all have here is that we're all medical imaging specialists. And we know there are a lot of tools out there in medical imaging. There's MRI, there's CT scan, and there's specialized ways of looking at the blood vessels using CT scan, MRI, and also using catheter systems like Dr. Elias was mentioning. So sometimes when the patient comes into the emergency department and you know that there's a problem, like the worst headache that person's like, then you really do go specifically looking for that abnormality of the blood vessel. Sometimes we stumble across these things, right? Patient may have an evaluation of the blood vessels of the brain, maybe just because they have a headache, and we don't really know what we're going to find, but an aneurysm might be discovered, or another vascular abnormality might be discovered, and that's another way we learn about these. Yeah, yes, absolutely. And I think one of the important things here is we've all know people or have heard of, let's say, cardiac catheterizations, right? Cardiac cath, and there's a lot of things in common here. And the idea being that if the heart is treated or the blood vessels of the heart are treated, right, they can be treated by entering the blood vessel in the leg, and various devices can be used to treat those blood vessels. And it's really the same idea for the brain. And Dr. Burke, you can speak to this too. These techniques are not only used in the heart and the brain, but in the arms and legs. If you want to comment.
Definitely, yeah, they're everywhere. Very common in the abdominal aorta or the big vessel in the belly. You might know people who've had aneurysms repaired also with similar techniques using catheters. can happen anywhere, and it can be devastating if they rupture anywhere. Used to be big surgeries to get these repaired, and now it's a couple-hour procedure and you can be done. It's amazing. I thought it was interesting that Dr. Elias talked about the continuum of care all the way from the emergency room presenting with these symptoms that are very vague, including the EMS services all the way to the emergency room, then to radiology imaging, then to radiology intervention, then to post-procedural care in an ICU or in an intensive unit. I mean, it's a big process, and figuring it out is the first step, and it has to be done quickly, and it has to be right. Sure. Yeah, that's a great question. If typically somebody's going to notice they've got a deficit, or a loved one will notice that they've got a deficit, either a drooping smile or numbness or weakness in an arm or leg, inability to speak or understand words, they'll typically be quickly brought to the emergency department, where our protocol here at Memorial is that they're going to be seen within, I think it's 10 minutes. They're going to be evaluated, and the stroke team is going to be notified that there's a potential stroke patient in the emergency room, and that triggers a whole chain of rapid imaging that's done in a priority, put ahead of just about everybody else, unless there's something else more acute going on. But they get quickly imaged, quickly diagnosed, and the whole team is brought together rapidly, and they're presented for a possible intervention within, I think it's 45 minutes. So it's really a quick process. You're going to see quite a whirlwind of activity if you're ever part of it. So thanks, Jeremy. Well, as Dr. Ellis, no, we could talk about that right now.
Absolutely. I mean, and that's part of the, this is, we're not only going to provide services for strokes, whether they are aneurysms or ischemic strokes. We provide the whole spectrum here of neurointervention. So yes, back pain is much, will address any issue with the spine, from saying treatment of insufficiency fractures due to osteopenia or lack of mineralization of the vertebrae or the spine, to treatment tumors of the spine, and as well as symptomatic areas of the spine where the spinal canal is narrowed. That's called stenosis, and we relieve that stenosis as well. So yes, that is a very much important part of neurointervention that we are offering treatment here at Memorial. Yes, I mean, I would discuss it with your primary care physician, and then and your primary care physician will obtain some images. And these range from plain X-rays to CTs or even MRIs, just depending on the severity. And we're forming a network of referral system here at Springfield, so that these primary care physicians know how to identify it and then make it aware and refer the patients to us. But certainly never, it always helps if the patient themselves saying, you know what, do you think I can get treatment for this? It's very important that patients are educated. The more questions patients ask, I think that's the best way to get the most out of your treatment, and ask the difficult questions to your doctors. That's the way to achieve a better understanding of the conditions. Correct. I mean, pipeline it's one of the new exciting devices that have come out in the market within the last 2 or 3 years. And what pipeline is a vessel, it's a stent that goes into the vessel. And more than saying coiling, like I was showing you at the last portion, one of the pictures, if you will. Let me just show you the picture that we had before, and I'll show you what the stent is. So you look at this picture here. Sorry about that. This is a stent. This is a stent right here. So the pipeline is more of a closed cell stent, meaning that these spaces are really tight together. And what they do is that we'll put them across an aneurysm. There's very specific sizes and location for it. It's mainly in the anterior part of the brain, in an area called the cavernous segment of the, I mean, these are fancy names, but it's in a very dedicated location. And that's what they are FDA approved for. And what they do is that they just direct the flow. Instead of the flow going like this and swirling around, once that stent is here, it'll bypass that neck and go distally. Yes, they have, I mean, where I train, and we're at Michigan, we were using them off-label for posterior circulation fusiform aneurysms, which is at normal dilatation of the whole vessel. These need to be done by a person. I mean, not all neurointerventionals do this procedure. They have to be certified by both the company and sometimes the FDA. They have to go through rigorous training, additional training, to be placing pipelines. When you're treating the posterior circulation, there are increased complications and outcomes to it. So I've seen both beneficial outcomes and, unfortunately, I've seen devastating outcomes. Fusiform aneurysms of the posterior circulation are very difficult to treat, if you will. If they're caught early on, the success rate for treatment increases dramatically. Unfortunately, usually when patients show up, they already have disability, and by that time, the treatment is limited. The other option is surgical. What they do is that they'll either bypass it or they'll clip that segment and then create additional, if you will, highways or bypass to perfuse the brain or deliver oxygen to the brain. As of right now, I am not trained to do the pipelines procedures. Again, these are very few centers, and they are the big centers in the country that are doing them, such as Stanford, Michigan does them, Mass General, and Harvard. So these are the type of center, because it's still very new and very investigational. So you need to be highly experienced for that. Yes. Yes, there is. There's literature, and I'd be happy to provide some literature review if you like. There is, fusiform aneurysms are more slow growing, and the problem with the saccular aneurysm is that this all has to do with the flow jet, or the direction of the flow of blood flow. When blood flows into this, it swirls, but then the weak spot, it'll be here. So if there's a preferential flow of blood going in this direction, that would be the weak spot. In fusiform aneurysms, there's swirling of blood, and then what the artery does is just enlarges like this. So these are more dangerous than the fusiform. Not to say that the fusiforms, once they are enlarged, they do rupture, and prognosis is very poor. That's why these are found faster than the fusiform ones. Absolutely. Again, what we'll do is that we'll have the primary care physician will refer you for some imaging. And when there's arthritis and degenerative changes at the joints of the spine, that creates an area of narrowing where the nerve exits. And if that's the case, in your case, for example, what we can provide is pain management for that. And we already have been providing this for, I mean, you can speak of the clinical radiologist side.
For several years we've been doing this. Always starts again with any. Sure, thank you for reminding me. There are a lot of reasons to have back pain or neck pain. So the first idea, of course, is to have some imaging, usually a CT or MRI, to try to narrow down what the possibilities are. Sometimes it's because there's not enough space between for the nerves, because there's some bone spurs. That's common. Sometimes there can be a disc herniation, which we've all heard of. So it's really important to know what might be the cause in the first place. And then we have a whole menu of different ways that we can potentially treat these, depending on what we think might be the cause. It could be trying to apply medication directly to a specific nerve that might be irritated. It could be a way of applying medication deep within the spinal canal so that it bathes several adjacent nerves. And there are even ways to relieve the pain if you have osteoarthritis in some of the joints of the spine. So there are a lot of techniques, there are a lot of options. You just have to start down the pathway of seeing what might be the cause of your pain, and then you can go from there. Yeah, so I should be more specific in talking about these treatments. What we're talking about are treatments which involve very carefully placing usually a small needle or other device next to the spine or next to the nerve that's being treated. These are done in a specialized room in the department of imaging, where we can see exactly with precision how we place these small needles and devices. It's a very minimally invasive procedure, just some numbing on the skin over the area. And from that point, we treat these areas directly. And the option of more oral medication would be more under the, which would be managed by a primary care doctor or someone who knows kind of the big picture of your health. But what they would do is we would work with them to see if we can use some of these very targeted techniques, carefully placed needles, medication administration, to see if that would help. Yes, please. Yes. Casey?
Well, it turns out that folks that have osteoporosis or that have a problem with their spine because cancer is spread to it can get a tremendous amount of back pain because the bone essentially breaks and collapses on itself. And there's a couple of different ways that can be treated, but one procedure that we've had some luck with is called vertebroplasty. It's also sometimes called kyphoplasty. And that's a procedure where we actually take a relatively large needle and under our x-ray guidance, press that needle into the broken bone and directly inject cement into the bone itself. And what that ends up doing is stabilizing the fragments so the bone fragments don't move, and that typically helps quite a bit with the pain. Now, of course, nothing in medicine is 100%. I wish I could say that we had a procedure that worked every time. But we've had some real luck with this procedure. We've had quite a few patients that have had considerable relief from their discomfort with it. That's a story we hear quite a bit with that. And we like to do this procedure because our patients do pretty well with it, and they're pretty happy with it. Like I said, it's something, though, that requires a battery of tests. Almost all the time we're treating back pain, it requires a battery of tests first because as we're implying here, there's 15, 20 different causes of back pain. And this is a specific cause of back pain when you have a broken bone, either from osteoporosis or from a metastatic lesion. So typically what will happen is you'll present to your doctor, and then we'll ask to get an MRI scan of your back and decide whether this procedure would be appropriate for the patient or not. It's not appropriate if the fracture is not new, or if there's some reason to think that the cement might leak into a place that would cause some problems. But most of the time someone has back pain, we like to start with an MRI scan or a CT scan to get a better idea of what's going on, and then tailor the treatment to treat exactly what the problem is. In this case, injecting cement to a broken bone. In other cases, like Dr. Russo was describing, you could put a needle right next to a nerve that's throbbing and inflamed because it's being pressed on by bone, and you can inject a bunch of numbing medication around that nerve or some steroids to decrease the inflammation, and that can provide relief too. Those are the kinds of things that we can do. Now, what we don't really do is the big-time surgeries that where patients have got to have their back sort of realigned with big pieces of metal, where they're using sort of carpentry to realign the spine. We don't really offer that. That's something that an orthopedic surgeon would do. But we do sometimes see these patients afterwards to help out with some residual pain.
Please, in the back. Sure. Dr. Burke, you want to speak to that, or Dr. Mealy?
Sure, that's another area. Same roadways we're talking about. We just take a left turn instead of a right turn, and we go down to the bowel, and we look at those vessels, and commonly they've got similar problems. For ischemic colitis, it's typically some plaque or some hardening of that vessel, and we commonly will thread our little devices through and open those up to relieve the blockage and restore blood flow. So sure, it's definitely possible. The workup typically starts with a special scan to look at the vessels. Maybe you've had that already, but certainly it's something that could be considered. No, certainly not more risky than in the brain, but it certainly has some risk, but overall the risk is much less than if you needed an open surgery to do a bypass, and the success rates are typically as good as or better than an open procedure. So it is a viable option for many people. Yeah, that's wise. Yeah, if it's not bothering you, don't typically want to jump on it. Now, that's not the case in an aneurysm necessarily, but you're right. The bowels are typically fed by 3 large vessels. So if there's just one that's diseased, then certainly 2 others can take over. It's all dependent on your individual circumstances. Okay. Well, you'd know it. I mean, it can be really debilitating and painful. So that's good, yeah. Sure.
Ma'am?
No. The stent is a retrieval device, the one that I showed you for the clot, is that we retrieve it and we take it out. The coils stay permanently. Yeah. So that can potentially also, if they're very large aneurysms, create a problem because they can create some pressure upon the nerves. If there's a large aneurysm where we have to put a lot of coils, the size stays the same. It does not change. That's where the pipeline, the main indication for the pipeline was for giant aneurysms, big aneurysms, greater than, say, 1 to 2 centimeter aneurysms, and that's where they were FDA approved, because that way what you do is that you put that stent that's really close knit together, and you bypass, and you don't have to fill the sac with the coils.
Any other questions? Occasionally, what we'll do is sometimes we'll participate in a couple ways. First of all, we'll participate in helping diagnose which lymph nodes are enlarged and where they are, and that's because we're all experts in interpreting CAT scans and MRIs, and that's part of our background. And the other main way we would contribute would be is if one of the lymph nodes were enlarged, as you're asking, we might be able to do a biopsy of that using the same kinds of techniques, not so much through the blood vessel, but because we can see the lymph node on the CAT scan or an ultrasound or another imaging technique, it can allow us to very precisely take a sample of that lymph node without the lymph node needing to, or without a patient having to go through a bigger surgery. So we do participate in diagnosis, and actually it's a big part of what we do. We would not be the ones, we would not be the ones who would remove the lymph node, which is sometimes what needs to be done, but certainly in deciding why the lymph node may be abnormal, we participate in that quite a lot. There's a lot of reasons for lymph node to enlarge, and sometimes it's just inflammation or infection, and sometimes it's tumor. How are we doing? Any other questions? Yeah, please, in the back. Yeah, I'm going to let somebody else finish that part, the last part of that question, but I know a lot of people, when they hear the groin, they're not really sure what we mean by that. And that's why often, another way to think of it is that it's the blood vessels that are really way kind of on the top of the thigh, okay? And that is, that's part of that blood vessel highway of arteries which are connected everywhere. So as it turns out, even though it's a lot farther away from the brain than other parts of the highway, just because the way the techniques have been developed, it ends up being actually a safer way to get into the blood vessel system. And because they're all connected, once that one blood vessel in the groin or top of the thigh, once the interventional radiologist, neurointerventionalist has safely accessed that, they can get just about anywhere else. They have specially shaped devices, catheters, wires that allow it to steer into different directions. So once it's accessed there, I guess I answered the whole question myself. Sorry. I might as well just keep going with it. So once it's there, it's really a straight pathway up through the artery, the big blood vessel, and through the abdomen and chest, and that allows us to get into the blood vessels of the neck and on up into the brain or anywhere else.
No, they don't. I mean, the nerve linings around the vessels are on the outside of the vessel, say on the surface of the vessel, and they're like a meshwork outside. So inside, there's no nerve endings, so the patients do not feel that. The only minor discomfort is when we put the local anesthetic, same thing they use in the dental office to numb up the skin, and then sometimes the prick of the needle going in. But other than that, there's no sensation or pain. So that depends on the procedure. Many of the spine procedures that Dr. Russo was talking about, the ones that we place the little needle, patients usually have what we call conscious sedation. So we'll put some medications in the same family as, say, Valium, to take the edge off of the patient and have them calm. In terms of the bigger procedures, they're done under general anesthesia, especially the aneurysm cases, because we don't want the patient to move in such a fragile area. And any sudden movement can make that catheter jump and cause damage. So for the cases of aneurysms. For the cases of stroke, there are two ways, ischemic stroke, when the patient's having a brain infarct. There are two schools of thoughts, if you will. One that believes, and is the one that I adhere to, is having the patient awake. The main reason is that I can see if my treatment is successful immediately by looking at the patient. That droopiness, the non-moving of the arm, I can tell the patient, lift your arm right there and then, and I can see the difference. So I prefer not to do it under general anesthesia. There's some data out there stating that general anesthesia also depresses the brain oxygenation. In any other general anesthesia case that you're having or anybody's having in the operating room, that is not necessarily a problem. In the case of stroke, brain is already damaged by lack of oxygen. Depressing more oxygenation can be catastrophic.
Please, Tom.
Absolutely. So what we're trying to do here at Memorial is, if you will, like a spoken wheel system. We have other outlying smaller hospitals where we're reaching out in the community as far as Missouri and Iowa and in the central and southern Illinois area. What we're trying is to educate these smaller hospitals to identify these patients having strokes and then successfully transferring them in the appropriate time period, either by ambulance or by Airbus, by a chopper. We are working very closely with the stroke neurologist here at Memorial, Dr. Muid, and where we are also providing these highly specialized cameras and putting them in the emergency room. And while the physician at that small hospital is looking and examining the patient, a stroke neurologist such as Dr. Muid can have a teleconference via the computer and see as this ED or emergency physician in the smaller hospital is doing the examination and identify whether the patient is a candidate or not for transferring. We are trying to achieve this from the outlying hospitals within a 2-hour span to transfer the patient. Once the patient is in our system, we activate what is called, we have a name for star 45, meaning 45 minutes from the door to making a decision whether the patient is going to be treated by me or be managed medically with the other medication that I mentioned, which is the clot-busting medication.
Please, in the back.
Yes, that's part of the equation. This medication, what it does is stops the normal coagulation system of the body. And we're injecting it into the whole body through the vein in the arm. So it increases the risk of bleeding tremendously, not only in the brain, but in any other part of the body. The time window is, there has been extensive studies demonstrating that after that time window, the brain tissue is already dead, and there's what we call breakdown of the cells. There's a barrier in the brain, and that breaks down, and the vessels become extremely fragile and very prone to bleeding. And we want to, at all costs, avoid bleeding in the brain. So now it confounds it. It adds on to another complication. There's an ischemic stroke, the tissue dies, and then on top of that, there's blood inside the brain. And blood in the brain is, outside of the blood vessel, is very, very toxic. And that's why the time period.
I have a follow-up question for that. So can you explain how it is that the interval for, or the opportunity to treat neurointerventional by going directly into the vessel, why that's a longer time period versus just the 3 to 4 hours if you were putting it in the IV? What's the difference there? Why can that be longer?
Correct. So as I explained, the medication is to the whole body, and it stops the coagulation system. It shuts it down completely. The clotting system in the brain, in the whole body. When I would go in, or the team here mechanically, what we're doing is that we're not applying. We could apply direct medication to that clot directly, just focally, and not to the whole system, not to the whole body. That decreases that chance of bleeding. That's why the window's larger. And also, the devices that I use are not stopping the coagulation or the clotting system in the brain. That gives us or affords the patient extra time. Once there's also a window for it. Once there's 6 to 8 hours lapses, that tissue, there's no way to recover that tissue anymore. And that tissue dies. And when that tissue dies, the blood vessels break down and also can bleed. But intervention affords an extra, say, 3 to 4 hour period time for the potential treatment. Now, the standard right now and the way things, it's in the medical literature and in most hospitals, is the medication comes always first, always. The medication does not work, or the patient's not a candidate for the medication, and then that's where our team comes in. I do not. I mean, that's not part of the practice of a neurointervention in terms of using hypothermia. There is data out there for that, especially emergency doctors and stroke neurologists do that. The idea of using hypothermia is to lower the metabolism of the brain, you know, and the need for the oxygen, for that, you know, the deprived tissue for the oxygen. And there's data proving that it works. But not everybody uses it, and not everybody's a believer out there in the medical community. But that's not part of my equation. That's not where I come in. I don't provide that service. That's mainly stroke neurology and the emergency physicians who do that.
Probably not so much. No, in the veins they become misshapen and dilated, much like the aneurysms, and they certainly do look similarly, but they've got a much different course that they would follow. So it's not easy to tie them together that well. There are different. I think I know where Craig's going to go, but there are many vein and arterial abnormalities that do affect the brain. We haven't really covered them tonight, but they are treatable with similar techniques. They're called arteriovenous malformations, varix, things like that can affect the brain, and those are treatable.
Yeah, I was just going to mention that varicose veins, even if they're not in the brain, treatment of those is also offered by our service. much.
You'd rather have them in your legs than in your brain, no, that's for sure.
So, Coumadin is another agent, another medication that is part of, also inhibits the coagulation time of the body. Body has, this is called the coagulation cascade, and there are different factors. There are internal and external factors in the body that affect it, and each step can be blocked off. Coumadin plays a role in one of those factors. It does affect, and it does play a role as to increasing the chance of bleeding if we give TPA. It increases the chance. Now, I'm not a stroke neurologist. This is a question that certainly a stroke neurologist is better prepared to answer. But from my knowledge and from my reviews, is that it creates a confounding or a potential problem to administer an IV TPA. Maybe you can help me out here, since you work with a stroke neurologist. What have you heard with Coumadin?
Thank you. You want to come and sit up here? I think there was a question front here. Maybe someone was thinking about asking a question.
Yes. So that depends on the size, shape, and location. If it's behind the eye, it can certainly create pressure to the and cause vision problems and pain. Patients do experience, if they're large, and I have to put a lot of those coils, they say they feel this pressure in their head. And it's difficult to treat, unfortunately, afterwards. I mean, I cannot take the coils out. The coils do not seal. The purpose of the coil is to create a framework for the body to heal itself and form a clot there and seal it off. So they cannot come out. They cannot come out. And depending on the size, shape, and location, they can cause problems. Headaches, this feeling of pressure in the head, vision problems. Because if I have to put a lot of coils, I can impinge on the nerve. Since it's not going to go away, and let's say there's a nerve going through here next to it, that can compress it and affect. Yes, I mean I can put from say 1 to 2 to 15 coils at a time. Well, certainly I tell the patients how much coils I put in after the procedure, but it can range from 1 to 2 to say 15. I mean, it's not unheard to put more than 5 or 6 coils in a case. That's not unheard of. These coils are very, very small. It's not like it's going to be like a golf ball. I mean, that can happen, but it's very unusual. It's very, very small. These aneurysms measure less than 1 centimeter. These are in millimeters, the aneurysms. And these coils are even micro coils, so they're very, very tiny. That's where sometimes surgery comes in also. If I think that's going to affect the patient by me treating it with coils, and that's why I sit down with the neurosurgery team and say, well, what do you think if this patient is a candidate for open surgery and they're going to recover maybe a little bit longer and have a little bit more post-operative pain, but in the long run won't experience this compression of the nerve because of the coils? Would clipping be the option? And what clipping means is that they would open the skull. I mean, it's a big surgery. They will open the skull, and then what they do is that they put kind of like a clip hanger for laundry clothing, if you will. It's a highly specialized one, and then they'll clip the neck. And that also stays in the body forever as well. But then this mass effect goes away, because what happens is when you put the clip here, it's analogous to putting it in a balloon, and then this decompresses completely. There's no more blood filling it, so the aneurysm collapses. That's the difference between doing it surgically and doing it through endovascular procedure. Mm-hmm. Mm-hmm. So that there's no established data as to how to follow up patients. What I do a 3, 6, 12 months, and if necessary, an 18 months follow-up. Meaning that I would bring back the patient after my procedure, and then I would, again, do an angiography catheter study. So that's the best way to do it. Now, there are other options. I'm explaining to you the ideal way to do it. There are other options, and we also provide this service here at Memorial. With MRI, we can also evaluate them. So usually when we do MRI of the brain to evaluate the vessels, we don't give contrast. But in certain cases, to evaluate aneurysms, we can do MRA or angiography with the MRI technology and put contrast, and then we can evaluate whether the aneurysm is growing or not, because we'll see either a leakage around here, we'll see contrast pooling around here, We'll see sometimes the coils on one side and the aneurysm sac filling on here with contrast. So there are ways. I mean, I think the best way is to do the angiography because it's what I can see it. I can see it real time. I can see what's going on. I usually move to doing MRIs after a year, 18 months. I feel comfortable that I can follow it with this type of imaging, with MRIs. But the gold standard, and there's no data out there disproving it, is to do the angiography. I know it's not a comfortable procedure. I mean, you've gone through it, so it's nothing comfortable. But it provides the best information. Is it not what? I'm sorry? The aneurysm, it's protected, right? The aneurysm sac stays. It stays, but it's cured, right? This is cured. The aneurysm here, it's cured. There's this mesh and there's clot in it. It's cured. But it's not going to go. It stays like this. But it doesn't bleed. It's secured, protected. So it doesn't matter whether the blood comes in here. It won't come in here and go through the weak spot of the vessel wall. It's protected, but it stays. Yes. There's no way to get rid of the aneurysm. The only way to get rid of an aneurysm is in the case where they're fusiform and the whole vessel's enlarged, and the surgeon will do a very, very big procedure, and then we'll clip here, and then we'll clip here, and cut that piece off, and then sometimes reattach it. And that's also known to happen in cases where there's no other option. But that's a very, very big surgery. And that's the only way to get rid. You're pretty much cutting off the aneurysm. But whether you clip it with open surgery, put a clip here, or whether you coil it, what I do, the aneurysm is there. It's not going to, it doesn't go, but it's protected. It won't bleed. Yes? That depends also. Hard to say. Hard to say because sometimes that pressure causes nerve damage that could be irreversible. That's one of the things. Second of all, it depends on whether you can go back or not. If I only put coils, it allows the surgeon to put a clip here. But if I have to stent it with this and coil it, the surgeon cannot put a clip because it crunches the stent and narrows the vessel down. And we can't do that. So in the case of sometimes, if the aneurysm recurs or the aneurysm itself causes too much pressure, certainly a surgeon can put a clip in here. Very rare would the aneurysm, after I coil it, will decrease in size. That's very rare. And granted, what we're talking here about is these are very large aneurysms that cause this problem. Usually the smaller aneurysms, which is what they are more common that we see, do not cause any problems once we coil. The majority, I would say, 85% of them have no residual pain or treatment. As for your example, you don't know what's going on. It's cured, it's secured, and there's no symptomatology afterwards. I'm talking about the aneurysms that measure more than 1 centimeter. They're the giant aneurysms that occupy space. Those are the ones that once you put the coils in. And those are, we were talking about that only 6% of aneurysms occur. I'm talking about now giant aneurysms, we talk about 1 to 2% of the U.S. population. So this is far, far rare. But there are options. We can, there are some options. The only problem is if we put a stent in, then options are narrow in terms of doing surgery afterwards.
Great question.
I think in terms of how, I'm not clear as to you're saying once I'm doing the procedure or after the recovery.
If I understand your question, if someone is unconscious and you don't know how long they've been unconscious, or someone wakes up that way, how do you know if they're within that period of time where they can be treated? Am I interpreting that correct? Okay.
I see. Yeah. We have a name for that. That's called wake-up strokes. And it certainly puts a very big limitation as to what we can do. Because since we don't know the time frame, now we have to weigh risk versus benefit of treating it, either by the clot-busting medication, the IVTPA, or versus the intervention. If a wake-up stroke happens usually in the anterior part of the brain, usually we manage it. Unfortunately, we don't have any other way to manage it but conservatively, because we don't know time periods. And these time periods are pretty much set in stone for now, because we don't have enough data. If it happens in the posterior circulation, meaning where the respiratory centers are of the brain, the ones that ignite the respiration and breathing patterns, that's also controlled by the brain. It's mainly by the posterior side of the brain. We take the risk because the consequences are so large, and patients, the outcome of not doing anything is almost always death. So we then are much more aggressive. That's if it happens on the posterior side. Unfortunately, if it happens on the anterior side, a wake-up stroke, it's hard to treat because we don't know, we tend not to want to violate those time periods because the risks are so large. We want always to avoid the brain from bleeding. That's far worse. Stroke is bad. Lack of, having an infarct is bad, but having it bleed increases the mortality significantly. So since we don't know the time period, we tend to be conservative in the management.
These are all excellent questions. I think we have time for one or perhaps two more.
So again, there's literature that it's beneficial. Both dual antiplatelets, meaning aspirin and Plavix, and there's no set guidelines, national guidelines. Where I train, we certainly were pretty aggressive with them, and we placed them. Regardless of whether I'm going to stent or not, usually we place this when we're going to stent for the majority of the times. So if I'm going to coil, it's not necessarily to keep the patient on Plavix and aspirin. Sometimes I keep them on aspirin if I think the coil's next to the vessel. I have one of the coil strings are next to the vessel. I want to be extra careful, and I'll place the patient on aspirin for a very short period. If I'm going to stent, problem with a stent is that blood is coming through here, and it's not in a straight fashion. Once you put something inside the vessel, it's called turbulent flow. Flow is not anymore in a straight fashion, and once blood starts swirling, it creates clots, and then the stent can occlude. So I usually would place the patient both on aspirin and Plavix before the procedure, and then do some tests to evaluate how effective both the aspirin and Plavix are to the patient. If I find that the levels are acceptable, then I'll feel comfortable putting the stent, and I keep them, and that varies, but usually from 6 months up to a year. They stay on aspirin forever. I'm talking about Plavix, either 6 months or a year. Aspirin is forever. No.
TIAs can be caused by a couple of different things, but it's almost always an interruption of the blood flow to some part of the brain for a very brief period of time. Lots of times when someone has TIAs, they've got a narrowing in the blood vessels in their neck that are leading up to their brain. And there may be either little tiny pieces of plaque that are breaking off and temporarily occluding a very small blood vessel, or the blood flow in the carotid artery itself is slow enough that for a brief period of time there's just not enough blood flow to one part of the brain. And then that can spontaneously resolve over time. The blood vessels we're talking about with strokes are when a clot, a relatively large clot, goes to one of the major blood vessels of the brain, and that's what we retrieve. We would never do a procedure like this for somebody that's got a TIA, but you might actually look at the blood vessels in the neck and either have a surgical procedure or have a stent placed to treat those blood vessels, because a TIA in itself can be a warning sign or a harbinger for someone that might be at risk for a future stroke.
Okay, thank you. Well, if there are no further questions, on behalf of Dr. Mealy, Dr. Burke, Dr. Elias, we're delighted to see you all out tonight, and I certainly learned a lot. And for those of you who are patients and in the community, remember you have talked to your personal physicians about some of the things that we mentioned tonight, and you can find a way to meet us or get a consult if you need one through your primary care doctor. Okay, thank you.